For those of us who have come across a case of intraocular foreign body in open globe injury, we know that it is just not a vision-altering situation, it's a life-altering situation. So we'll be going beyond the surface today and delving into the outcomes of intraocular foreign body in open globe injury. The range consists of 16 to 41%. So for every 5 open globe injury, the chances are that 2 cases will have intraocular foreign body. And if left unchecked, it could lead to severe inflammation, endophthalmitis, blindness, and thereafter phthisis. So we at LBPI did a study to find the significance in deriving the visual outcome based on mode and location of injury, time of presentation, time of intervention, basically to see the determinants which define which patient sees and which patient suffers. So it was a study conducted in GMRV campus Vishakhapatnam of LV Prasad Eye Institute. It was a retrospective observational study of 115 patients of 121 eyes. We did an elaborate exercise on patient demographics, injury details, clinical findings, surgical intervention, visual outcome. And these were the results that we were able to find out. This was a study of 115 patients with 121 eyes. The average mean age was 37 years, mostly young male of 19 to 40 years. And the average mean time of presentation was 24, although the median was 2 days. To our surprise, most of the cases that we came across came in the later half of afternoon or later in the weekend. And about 3/4 of these injuries were workplace injury, out of which 50% were due to hammering or chiseling. If we look at the univariate analysis impacting the visual outcome, we saw, although statistically insignificant, but there was a contribution of corneal penetrating injury and non-metallic foreign bodies. There were more anterior segment findings as compared to posterior segment, and involvement of retina and endophthalmitis played a significant part in deriving the final visual outcome. So the mean best corrected visual acuity at presentation was logMAR 1.66, which nears to legal blindness. And if we look at the final best corrected visual outcome which we were able to attain was 0.98, which is moderate impairment. Running the multivariate analysis of independent risk factors, we were able to find 3 independent predictors for poor visual outcome, that is poor best corrected visual acuity at presentation, retinal involvement, and patient presenting with endophthalmitis. Looking at the logistic regression of independent risk factors for predicting traumatic endophthalmitis, although the location of intraocular foreign body did not have much significance, but involvement of posterior segment finding was very significantly associated with incidence of traumatic endophthalmitis. So if we have to concise the results, looking at the demographics and workplace safety, occupational hazards associated with high-risk labor mandates the use of protective eye care. If we look at the timeline, there are 2 perspectives here. From the patient perspective, the more number of cases presented in the later half of the day or later half of weekend, that could be because of fatigue, work-related stress, increased workload that could lead to increased injury rate. And from the healthcare perspective, there has to be greater vigilance and preparedness during this hour because this is the high alert time and high influx time of the patient. Looking at the IOFB composition, there were more number of metallic foreign bodies that presented to us, but non-metallic foreign bodies were associated with higher traumatic endophthalmitis, almost double of metallic. And 3 independent predictors of poor visual acuity was first, poor best corrected visual acuity at presentation, presence of vitreous hemorrhage, and retinal hemorrhage, retinal involvement in terms of tear detachment or dialysis. And the presence of posterior segment findings was associated with traumatic endophthalmitis irrespective of the location of IOFB. So if we have to conclude the study, we can come to 3 P's: preparedness, protocol, and prevention. Prevention in terms of using protective eye care, eyewear in high-risk occupational settings. Protocol, if you're suspecting a non-metallic foreign body, start antibiotics early. If you're suspecting vitreous hemorrhage, retinal involvement, prioritize surgery. And preparedness in terms of if more number of healthcare professionals allotted in afternoon or during weekends where there's going to be high influx of the patient. Thank you.
So what I'm not getting is that what is your take-home message particularly? Because if I say this study we have already done many times before, many generations.
What is like?
So what is the
what's
difference
originality?
here?
So one take-home message is about the timeline, ma'am, that there are going to be more patients during afternoon and during weekends. So there has to be a mental preparedness amongst the healthcare workers. And the second is the difference in endophthalmitis presentation. So normally, metallic foreign bodies will be associated with endophthalmitis, but in our study, it goes against more of the studies that say non-metallic foreign bodies uh, are not so often associated with endophthalmitis as compared to metallic foreign bodies.
See, most hospitals run a 24/7 emergency.
Yes.
So if manpower, I don't think is a crisis here. But the point is that have you actually done the prognostic factor according to your OTA score?
Yes.
And how is it?
The prognosis?
Yes, according to your OTA score?
According to the visual outcome, we were able to,
Yes.
so all the patients here went for surgery within 2 days. And we were able to attain good visual prognosis for all these patients. But additionally, what we saw that if there's an additional intervention that was associated to any of the patient, that also led to poorer visual prognosis for these patients.
Sir.
Again, was there any microbiological thing that you found? What was associated with the non-metallic and what was associated with the metallic?
We haven't come to the difference between metallic and non-metallic, but if I tell about the endophthalmitis cases, most of the cases that we came across were gram positive, followed by gram negative, as we often see.
And what are the sensitivity patterns that in your area? I mean, wouldn't that be able to guide the future? You know, when you do your second audit, you would know the sensitivity patterns from the first audit, and then make the instead of an empirical antibiotic, you would
We
probably
can do
not have an
that.
empirical, but
Yeah,
you
it will
didn't do
be.
the sensitivity studies.
We haven't moved that much.
So I think one thing that I would like to add is it is very important that when you are exploring a trauma case, you always take either a AC tap or the wound swab. Something you have to take because ultimately you are going to start this patient on steroid. Okay, if you don't take a swab or something from the eye while repairing it, you might actually land up into endophthalmitis. So that is one of the very important thing. So it might happen that your metallic cases actually had some superadded infection. It depends upon the time that the patient are coming.
So all these cases went for culture sensitivity of intraocular foreign body. If AC tap was done, that AC culture sensitivity, and if vitreous tap was done, vitreous culture sensitivity.
They were has what sir was asking you, right?
So did you come? What would your recommendation be? So suppose I say I'm coming to your institute and I'm doing a foreign body removal. What would your recommendation be on what particular antibiotic, and what would that be based on?
So
You would
if
say
we
use this antibiotic.
if we suspect a traumatic endophthalmitis in cases of open globe injury and we have excluded intraocular foreign body for that patient, we go for an empirical treatment that consists of voriconazole, amphotericin, and itraconazole.
So have you noted fungal infections in your cases?
Yes,
Is that what you're trying to
they were
tell?
pretty less. I cannot recollect the number, but yes, they were there, that too.
Fine. So we'll